have a question for both of you, Johann. What about the neutrophil? You don't seem to talk a lot about it in terms of the crosstalk, the pathogenesis, and I think it has a relation to pustular psoriasis. What do you think about that?
It's a great question. I think, if you think about it, how IL-36 cytokines actually work, they actually are secreted as full-length cytokines, and they're fairly inactive. So to really activate them, you need the neutrophil proteases to kind of trim them. And when the trimming happens, the biological activity of them goes up by about 500-fold. So I think that's where the neutrophils really play a role. They contribute to the processing and activation of the IL-36 axis. So that's when we are looking at it in terms of gene expression and histology. Most of that IL-36 activity is typically right around the neutrophil pustules. And then in addition to that, neutrophils actually release other agents such as the S100A8, A9 protein that actually can act as toll-like receptor agonists. So they can amplify inflammation through multiple different means. And I really think that they do play a role.
Thank you, Johann. Hervé, the question of, is it psoriasis? Is it not psoriasis? I understand that we've talked a lot about the separation between both. We've talked a lot about why this is different. But on the other hand, over 60% of psoriasis, of pustular psoriasis patients already have plaque psoriasis. Now, how is this? I understand that the genetic mutation is one important factor. But clinically speaking, how is this going to impact my treatment regimen? Because as you know, coming from Egypt, we have pustular psoriasis patients, and we are, it's not easy to get the newer anti-IL-36 regimens in treatment. Hopefully we will, but I mean, if I get a patient who has pustular psoriasis without any other, does this tell me that this is more like IL-36 as opposed to a patient coming, which I usually see? The past week I've seen a child, 6 years old, with psoriasis, who developed a severe case of pustular psoriasis. What am I going to do with him? So, of course, I understand the genetics and the difference, but it's becoming a little mixed up, and I think you've summed it up really well. A different taxonomy is needed, a different classification maybe. We need to think about the disease in different terms. I don't know what you think about that. Thank you, Hervé.
Well, thank you, Mahira. And that's really a great point. I showed the cartoon from the publication was coordinated by Jim Kruger. I mean, these two separated mechanistic scenarios. Johann presented brilliantly the role of IL-36 in psoriasis vulgaris as an amplifier, right? So, pro-proliferation of keratinocytes, pro-inflammatory cytokines. If that would be the intersector, that basically the IL-36 is really like fuels in a sort of in a subset of patients with a genetic determinant of psoriasis vulgaris, then the patients with IL-36RN mutations, they should show at least some of them psoriasis vulgaris. Yeah. And overall they don't. Mm-hmm. So it doesn't resist to the epidemiological facts. I mean, massively the patients who have concomitant GPP and psoriasis vulgaris, they are not mutated for IL-36RN. Very few are mutated for CARD14. Okay, this gene might account for some cases, but overall there should be some other genetic determinants. Now the question is, should there be on one side a genetic determinant of psoriasis vulgaris, on the other side of a determinant of GPP, but in this case, why 50% of the patients with both? Yeah. So we work on the assumption that there are other genotypic determinants that are intersecting, that are driving two different disease. Well, at least two different but intersecting disease.
Thank you.
Great point.
Might perhaps the determinants of variations in topographic variability and even within a family or within the same individual be based on epigenetic alterations rather than genetic?
Absolutely, could be. Again, you know, we don't see in the same pedigrees the patients with GPP and psoriasis vulgaris. I'm speaking of the ones with either CARD14 or with GPP. So I mean, I'm not sure that I'm sure that epigenetic modifications might account for the disease severity heterogeneity. That's for well, pretty expected. But for the very different phenotypes, I'm not so sure. Again, I mean, we have to.
There might be other genetic determinants not yet discovered.
Yeah, that's yes. Yeah, exactly.
Thank you. Just, I have one question about the role of interleukin-36 and polymorphonuclears. They don't have interleukin-36 receptors, and I wonder, the way in which they are attracted to the keratinized epithelium seems to be dependent on signals from keratinocytes themselves. So it's kind of a self-activating loop. Then I wonder, apart from the epidermis and perhaps the infundibula in HS, is there any role of interleukin-36 in any other disease in other organ or whatever, even in the dermis? Is it relevant? So it's purely for pustule, intraepidermal pustules or any?
Well, maybe you want to comment. Well, I could start, and then I'm sure that Johann will wrap it up. The IL-36 system is really expressed in the epithelia. I mean, that's really the major, one of the major defense system against probably some infection. It evolved from a duplication of genes belonging to the L1 family. So that's why you have at the digestive tractus level, but also in the bronchial ducts, you have intense expression of IL-36 and IL-36 receptor, especially in the bronchial ducts following some viral infection. And that's why IL-36 receptor targeting antibodies are following some development in IBD. But you need the neutrophils, like Johann says, because when you have the immature IL-36 agonists, you need the protease from the neutrophils to cleave and activate, transform into the bioactive form. So this kind of couple, epithelial cells and neutrophils, is the key therapeutic target.
Well, this first, the polymorphonuclears coming and activating interleukin-36, or interleukin-36 activating epithelial cells to attract polymorphonuclears?
Johann?
Yeah, no, it's a cascade. If you look at which cytokines actually are very active in activating IL-36 expression, it's actually the typical, the ones you always think about. It's IL-17, it's TNF, IL-1 and IL-36 itself. It's a self-sustaining cycle, so IL-36 will induce even more IL-36. And then if it gets secreted, then you get more activation. It's a vicious cycle, and I think that's what's happening in GPP when that axis kind of gets out of control. There's a very complex mechanism in the epidermis how this is regulated. So there's a multiple different serine protease inhibitors. Serpin A1 and A3 are just a couple of them. So we really do not understand well what is the natural endogenous system in the epidermis that really shuts this cascade down. But it's one that is easily set off by multiple different cytokines and toll-like receptor agonists. But again, and we understand that side really well. We just don't understand well what really shuts it down.
Thank you very much. That was a question.
Good morning. My name is Margarita Velázquez. I'm APC counselor from Colombia. So thank you so much for the lectures. What we know about the netosis role in GPP?
Sorry, about?
Netosis.
Netosis.
Oh,
in
netosis.
GPP.
Oh, yeah. Well, that's a great question. Well, we don't know much about the in vivo release of neutrophil extracellular traps, but the proteases that are massively released from the neutrophils, as you know, they are decorating the chromatin motifs of the net. So elastase, protein S3, and so forth, they are mainly attached to these nets. So Yes, I mean, it's clear that the sort of netosis is very likely and surely happening in GPP. And that's the way to, again, to activate both the agonist and the antagonist, by the way, because the antagonist is also cleaved by some proteases to be bioactive. So that's, yeah, great question. Thank you.
Thank you. There's one question. Johann, you were talking about regulation before, and I'm always wondering, in single-cell transcriptomic studies, biopsy specimens are taken for lesions, but no mention is made regarding if the lesion is worsening or improving. So is there any study that somehow takes into account the kinetics of the lesions in order to look more closely on regulation? I mean, the role of, for instance, B cells or fibroblasts in bringing down inflammation, or some other cells in bringing it up, because the information is just from what snapshot.
No, it's a great question. It's and you kind of hit it right on. It's like when you look at the literature, you feel like we know everything about psoriasis, but we don't. These studies are really not being kind of done longitudinally to kind of monitor, changes in the natural course of psoriasis. We have limited understanding on how treatments actually affect the immunological cascade in psoriasis. We know a little bit, but there's a lot of gaps. And in terms of these natural fluctuations and shifts in immune phenotypes, such as with like paradoxical type reactions, huge gaps. We just don't know the mechanism. It really hasn't been explored.
And sequential studies of sequential studies of lesions have been done?
Same thing. Very, very limited number of studies, and usually done with like not the newest technologies, maybe microarray or RNA-seq, and still, even at that level, very limited. So when you think that we have solved psoriasis and we're done with it, we're nowhere close.
Thank you. There were very nice pictures of which somehow reproduced the histopathology of psoriasis. There were fibroblasts, eccrine cells, B cells. Any comment on these forgotten neighbors?
It's a great question. It's actually it's a much more dynamic disease process than we appreciate. Like fibroblasts actually seem to have a major role in psoriasis, and might actually be an amplification loop as well. It secretes a number of chemokines and cytokines that should activate the inflammation of psoriasis. And actually, interestingly, B cells are actually in psoriasis. We always kind of ignore, just don't think about B cells in skin and in skin inflammation. But there are quite a few B cells in psoriasis, and what they're doing there, we really do not know. They're not your typical B regulatory cells, and they're not your typical antibody-producing cells. But they're there, and they like everything, they gotta be doing something.
Question. Hervé, I wonder about polymorphonuclears in not just pustular psoriasis, but also in HS. Many of the drugs we are using have been tried with some disappointment in lesions with pustules, acne, hidradenitis suppurativa, and like. Any comment on that? Is the driving this polymorphonuclear influx different from interleukin-36 receptor?
Yeah, well, great question. Again, in HS, everything is in the lesions to tackle the hypothesis that, inhibiting IL-36 would be beneficial, right? Or IL-1 and IL-36, because you have the two families which are represented in lesions. You have NETs, you have netosis. This has been shown in the HS lesions. And so far IL-1 inhibition is rather disappointing. IL-36, we'll see. But maybe it's even inhibiting both because there is a common chain, the IL-1 receptor accessory protein, which is common to the IL-36 and IL-1 receptor. So there are some inhibitors which are coming. We have to see, honestly, the statement that because there are some neutrophils, they should be either IL-1 or IL-36, I doubt that. I think it's more, segmentation than stratification. And outside this field, there are other neutrophil attractors than those. But I think it deserves some to be tackled and to have some drug development. One thing is for sure, we don't find IL-36RN mutations in patients with severe HS or the severe PAPASH and SAPASH and other syndromes.
And I'll kind of add to that. I think where we see most of the IL-36 activity in HS actually is along the sinus tracts, the epithelialized sinus tracts. And if you think about how we design clinical trials in HS, we're actually looking at the acute inflammatory lesions, not the chronic ones, the sinus tract. So again, there's quite likely some clinical response in HS to anti-IL-36 treatment. We may not be focusing on the right thing.
It seems that polymorphonuclears that get close to the epithelium are more intent on activating interleukin-36 than on destroying things.
Yep.
Okay.
Exactly.
Thank you. Next question.
Just one question. Very
Alexander.
interesting. So sometimes clinically we see that patients get resistance to cytokine interruption, and it's not just anti-product antibodies. So we believed that there might be some immune cloud of cells that basically you shift it if you inhibit one axis, like in your nice diagram, towards the other. Mm-hmm. But this concept is very diffuse, and I'm constantly trying to see whether there is some evidence that backs this up. So do you have some inkling on how we could prove that or go after that?
Well, I certainly agree with you that there is probably an immunological shift that some of these targeted treatments actually induce. And you see that when you take patients that are biologically experienced and you switch them over to a different class, they tend to respond more poorly than biologically naive patients. And I think the paradoxical reactions are probably the best example of it, and you see a very marked shift towards type 1 and type 2 interferon responses. So I think in terms of the mechanism, I think that probably is the easiest group to kind of study in terms of what's going on. But what drives it and what predisposes to it, we only see it in about 20% of patients that are treated with like an anti-TNF agent. So it's a very, very small subgroup. And there's got to be some kind of a marker or predisposition or genetic predisposition to have that kind of a shift. But it's very difficult to kind of sort that out in a clinical trial to kind of separate the primary failures and then the secondary failures in this immunological drift that is going on. And again, that kind of comes back to it's one of those things that is still massively underexplored.
Exactly, so kind of the interaction between the clouds, that would be interesting to analyze.
Yeah, exactly.
Thank you.
Thank you very much.